Hi everyone. Today we'll discuss about Achalasia cardia. So whenever we swallow food, the primary peristaltic movement will carry the food bolus to the lower esophageal sphincter, and there will be a transient relaxation of this lower esophageal sphincter following the primary peristalsis of the esophagus, which causes the relaxation and the food bolus enters into the stomach. So this is the normal physiology. What happens in Achalasia cardia is, this sphincter is in a hypertonic state because of constant contraction of the circular muscle fibers of the lower esophagus and the cardia. So it mainly affects young females, and the reason being idiopathic or neurogenic degeneration. So coming to the pathogenesis, as I told earlier, the LES will fail to relax. So there is stagnation of the food bolus in the esophagus, causing the esophagus to dilate. So there are primary peristalsis, secondary peristalsis of the esophagus, which try to overcome this obstruction, but eventually there will be loss of this esophageal peristalsis and the esophagus starts dilating. So it presents with a classical triad of dysphagia, regurgitation and weight loss. So there will be difficulty in swallowing the food. So the patient feels there is something stuck. He is not able to completely swallow the food, and he feels it is stuck in his chest, and there is regurgitation because of the stagnation of the food particles. So there will be regurgitation, water brash can be present, and due to lack of food intake, so there will be weight loss. So other symptoms are heartburn, postprandial choking and nocturnal coughing. So when the patient is lying down in a supine position, so the stagnated food particles can get into the respiratory tract, causing coughing, choking, and heartburn is also due to the fermentation of these food particles irritating the esophageal mucosa. And this usually begins with the liquids and progresses to the solids. So this can, on as the disease progresses, it causes retrosternal pain and heaviness, and these repeated aspirations can cause lung abscess and pneumonia and even bronchiectasis. So Achalasia cardia is a pre-malignant condition. Squamous cell carcinoma is the most common type. This is because of the fermentation of the stagnated food particles in the esophagus, irritating the esophageal mucosa, resulting in malignancy. So how do we diagnose this condition is using a barium swallow. So in this barium swallow, you can see that the esophagus looks dilated and there is a smooth tapering at the lower esophagus, giving rise to a bird beak appearance, and there is no gastric air bubble, which is usually present in normal patients. So it is absent of air bubble because there is no lower esophageal sphincter is not relaxing. And the manometric studies is the gold standard, which will show the pressures at the lower esophageal sphincter as well as the peristaltic movement of the esophagus. And what is pseudoachalasia? It is the failure of relaxation of LES, but due to gastroesophageal tumors, these are usually submucosal tumor causing narrowing of the lower esophageal sphincter, and there could be strictures also. So coming to the treatment, so first is the non-operative medical treatment such as sublingual nitroglycerin nitrates or calcium channel blockers. This will cause relaxation of circular muscle fibers and causes relaxation of the LES. And or next is the endoscopic. So pneumatic dilatation. So dilatation using balloons. We'll pass an endoscope and we dilate the lower esophageal sphincter, or injecting botulinum toxin, which results in blocking the acetylcholine release and inhibits the smooth muscle contraction, so which results in LES relaxation. So the next is the operative. The most commonly used is modified laparoscopic Heller's cardiomyotomy. So we divide the circular muscle fibers of the lower esophagus and the cardia in this procedure. So since when we divide the circular muscle fibers, the lower esophageal sphincter becomes lax, and these patients are predisposed for gastroesophageal reflux disease. So to prevent this, we combine this procedure with an anti-reflux procedure, usually TOR or top-it fundoplication. So the next one is per oral endoscopic myotomy. Here we pass an endoscope and create a submucosal tunneling and enter to the muscular layer and divide the muscular layer present in the distal esophagus, LES and cardia. So the indications of esophagectomy. The removal of esophagus are megaesophagus, tortuous and dilated esophagus, or sigmoid, very hugely dilated esophagus, or failure of more than one myotomy procedure, and or there is some reflex stricture which is not responding for dilatation. Thank you.